Welcome to the Health and Care Planning podcast from the AHCWP. My name's Joanne Smith, and this is a recording of a training session on Workforce Redesign hosted by Colin Lewry. The recording starts with Colin describing where Workforce Redesign fits into the context of workforce planning.
So this is sort of firmly in the how to redesign workforce space. And I've actually based this around a course around process mapping, which will become hopefully clear as we go through things. So if I look at redesign as a whole, there's lots of different approaches, as we've spoken about before. There's things like 6-step can be used to redesign. You can use lean, you can use WRaPT, you can use STAR. There's all sorts of different approaches you can take to doing workforce redesign. We use one called WRaPT redesign. We use that because it is a useful little tool that you can use alongside all the others. And it's also an approach which is free to use and completely publicly available. So WRaPT redesign is an approach that we use, and that takes you through everything from scoping and mobilizing a redesign all the way through to implementing that redesign. And that goes through understanding your current state and your future state and modeling that state through that process. What I want to talk about today is workforce redesign. When we're considering redesigning workforce, there's lots of things that can make a massive difference to the workforce numbers and the workforce types that you've got. So you can change the process itself. So if you take steps out or add steps in, that might change who needs to do it. It might change how many staff you need it. So you could argue that process redesign is workforce redesign. The same if you add or take away some digital solutions, and the same could be said for equipment, then you can also change the type of staff you need and how many you need. You introduce EPR, you introduce artificial intelligence, you may need more cybersecurity people and fewer people doing administration, for example. So that can change roles and numbers too. An area that's quite close to my heart at the minute, because working on new hospitals, is estates. But if you change the estates, if you change the building, the rooms that people are in, etc., then that also can change the number of people you need and the type of people you need. For example, if you introduce lifts, that might change the type of staff that you need. If you introduce single rooms, that might increase the number of cleaners you need, etc., etc., etc. Finally, you can change organisation structures, and that can also change your workforce. So if you bring two organisations together, if you vertically integrate with between hospitals, GP practices, if you merge social care and health, for example, then you will also change the number and type of people that you need. So all of that stuff can be considered workforce redesign to an extent, but it's not the area I want to focus on. What I want to focus on is the little core of this that people often challenge us as workforce planning or workforce redesign specialists with, is how do you redesign the roles itself, the actual changing the workforce that are doing things. And what I mean by that is replacing who's doing what with different roles or considering specifically workforce elements. So I'm going to talk about workforce today, and it's an area we talk about with role redesign. Now, role redesign, as far as sort of the way we do things with WRaPT, is taken from looking at multiple different ways that role redesign is done in all aspects of workforce redesign, not just health and social care. We're thinking about how it's done elsewhere. And we looked at 5 specific different areas of job analysis that can be done. One is functional job analysis. One is called task inventory. One is called the job element method. One is called the narrative task, and the other one is called critical incident. Now, they all do things slightly differently. I was trained in functional job analysis when I grew up, but there are lots of different ways of doing it. Some of them are sort of slightly more groovy than the others, like the narrative task one is based more around thinking about the story of why you're doing things and understanding the reasons why you're doing things. Whereas functional job analysis is much more about what are you doing, how long does it take, etc. Critical incident's quite nice because, as I remember, that is generally looking at things as how things work when things go wrong and thinking about what would happen if things do go wrong. So it's looking at things from a different perspective. But they've all got their own little strengths and weaknesses. So what you've actually got is some core elements, and then you've got some things that you can add to it. So role redesign, when we're looking at things the way we're going to look at things this morning, we look at some core elements. So basically what they do is they all analyze the tasks that are being done. You need to understand what needs to be done. They all, to some extent or another, tend to rate how important they are. So thinking about which ones are the most important and which ones are less important, and all of them consider what skills are needed. And it's the sort of the first and the last ones that I consider the most important. So what are we doing and what is needed to do it? And when we think about analysing the tasks that are being done, some of them think about service user need. And so it's certainly worth thinking about service user need. Almost all of them think about that, in fact. They all break down the steps, and they all, to some extent or another, consider the need for staff and what the impact is on staff of each step. And when it comes to the skills that are needed, they often consider a few things. They obviously consider the actual skills, the competencies, but they also consider the behaviours and attitudes that are needed. They consider whether you need to be qualified to do it, and they consider legal requirements around what skills are needed, because that can set what staff are needed. And they also consider who is doing it now and why are they doing it now? What's the reason why we've got a social worker doing it, a nurse doing it, for example? What is the reason behind it? So looking at the core elements, you can see that there are certain things that they all share. Then when we're considering things, we think about certainly some basic data, and then we think about some possible data. So when we're looking at what people do, we ought to be able to describe what they do. And that's to make sure that we're all clear on what we're talking about. And we need to know how often they're doing it. So if we're thinking about role redesign, we tend to think about, if it's being done once, if it's done 10,000 times a year, etc. That helps us with this, and it helps us with modeling. And when I say number or chance, what I mean by that is, and it will become clear when I sort of look at process maps, is that the chance of something happening is important when we get to a thing called a decision step, and we'll pick that up in a second. We need to look at the time each one takes. That's important because it gives us an idea of scale, especially when multiplied with the number. If it's only done once a year, and it only takes a couple of seconds, you'd have to wonder why we're even looking at it. We obviously need to know who does it, and we need to know what skills and all the other things above are needed. By above, I mean qualified or unqualified, who's doing it now, the competencies, the behaviours and the attitudes, and the legal requirements for that step. But there's loads of other things that we might consider. We might consider what data and equipment are needed to do that step. We might consider what makes that step excellent. We might consider what is the story or the narrative around that step. So why is it done? What are the reasons, etc. We might consider what are the consequences if we don't do it right, which comes from critical incident. And we might consider what makes it a good role, what makes it a good thing for staff to be doing, what's the value to staff of doing that step. So there's loads of different things we can consider when it comes to role redesign. So I'm quickly going to run through a few elements of process mapping and what that means specifically when we're considering these steps, before coming back to these and reconsidering them, and then looking at some other aspects of role redesign. So if I move on, so I always consider when we train this in real life, and we get people to actually do it, which is far more fun than listening to me drone on over Teams. But the simple process that we often look at is the following. So a referral is received and it's reviewed. If that referral comes in as urgent, then someone else reviews the referral to see if it is simple or not. If it is simple, then a GP clinic is held, admin is handled, and the process ends. If it's complicated, then it's sent to a tertiary provider. So that's how we handle urgent things. And if it's non-urgent, then a nurse clinic is held, admin is handled, and the process ends. So what we like to do is consider what this looks like in a process map. But a process map typically considers a few things. When we're looking at a process, we tend to have a start and an end point. We tend to consider the inputs and the outputs. We need to consider the processes, and we consider these things called decision points. And a process step, an activity step, we often show as a blue square. So in this particular case, if we receive and review that referral, then we've got a blue square that says so. And then we typically use a red or purple diamond to consider the decision point. So, for example, in this particular case, when we've received and reviewed that referral, if it is urgent, then it goes one way. If it's non-urgent, then it goes another. And there are all sorts of fun steps to this. For example, yeses to decision points should always go down the page and no's should go across. We can show going from the top of the page to the bottom of the page. The fun thing also about setting things out in a process map is that by looking at the number of decision points, we can often see how complicated a role is. Typically, the more complicated that role is, and therefore the higher band of staff or more training is required. So you draw out that simple process in a process map. What you also then consider is think about other things. So who does each step? What skills are needed for each step, what the scale is, what the chance of each decision point is, etc. Where the input comes from, what the outputs are and where they go, and how long each step might take. And you can collect that information. So in my original, when I first started workforce planning, I did a lot of time in motion. It meant that I sat around with a stopwatch recording people's processes and recording the time it took to do each step. What I do in each particular case is consider a few different things about each area. So, for example, when we consider receiving and reviewing the referral, we can record that there are 10 per day. We can record that it's done by an administrator. We can recall that it takes 10 minutes to do them. We can consider the skills that are needed. In this particular case, you might say organization, filing, behaviors and attitudes. We might say the attention to detail. We might also consider how the percentages associated with each of the decision points. About 50% are urgent and 50% are not urgent, for example. And we consider how simple things are. So, for example, a simple case that goes to a GP clinic happens 99% of the time. A referral to tertiary will happen only 1% of the time. So we can start to write down on our process map a few of those additional bits of information that we talked about. But one thing to consider is that the stuff we've process mapped is not all that the staff are doing. So you can't just add up all of those steps, all of those percentages, all of those times and go, right, well, we need X number of staff based on that, because there are lots of other things. Don't forget that there'll be other tasks that they're doing, that they're not just doing this. Don't forget that they have tasks that will be, or things that will happen annually. They will go on leave. There will be sickness. There will be training, conferences, and other time to be put aside, and there may or may not be maternity leave that people take. That's where the kind of 23% additional, 23 to 27% often gets added to nurse establishments, for example, or the 44 weeks that's considered for doctors, for example. That's where that often comes from, but don't forget that. Don't forget also the concept of downtime, by which I mean that whilst it's all very well saying this step takes this long, on occasion things can happen that you don't take account of, and also people will need time to move between tasks. So that downtime can sometimes be anything up to 30%, potentially even more, of people's time spent moving between tasks or whatever else. So don't forget, don't just add everything together if you are modeling things. That downtime is breaks, it's making mistakes, it's moving between tasks, it's random things. I once did some timings at a post office, for example, and one of the people in the queue fainted, for example, and needed to be helped. You can't put that in a process model unless you're very, very specific. So bear those in mind. So hopefully, coming back to role redesign, you can see that a great way of working out how long people take around things and what people do is by coming up with a process map. And on that process map, considering the tasks that need to be done, the skills that are needed. I haven't gone through there rating how important they are, but again, that is something you can do in terms of thinking of the importance, and we'll look at that in a table in a bit. And then you can consider the various bits of basic data, the description, the number or chance, the time each one takes, who does it, and what skills are needed. And add any of the possible data that you might want. For example, what data and things are needed, what's excellent, what the story is, what the consequences of doing it, and what makes it a good role. And you can put all of that into a table. So that table simply sets out the step, who does it, the importance of that step, the competencies needed, the behaviors and the attitudes needed. You could consider other roles who could do that role. So is there anything stopping a role from doing it, either because of law or because of skills? And you consider various different options around who could do that role. And let's think about how do we come up with those options. Well, whenever you're coming up with new roles, it's more than the steps that they do. And you can consider all sorts of different ways of doing this. So what you can do is consider giving the steps to the cheapest person that can do it. So, for example, if in this particular case an administrator is the cheapest role, you could give all administration to an administrator, for example. And that happens quite a lot. We quite often hear top of role, or sometimes slightly less fun, sweating the asset, which is lovely. So you can say to people, right, we want you to do just the roles that just you can do. So that's one way you can look at it. You can look to try and combine things together so that somebody has a view of the whole thing. And this can be quite interesting because, of course, you've probably had examples of where someone's done one bit of a process, then somebody's done the second bit of a process, somebody's done the third bit of the process. Nobody owns the process. And so we end up with the thing being a bit of a muddle. So you can look at that. You can also look at combining things to make the role more interesting so that somebody isn't just doing one tiny thing and then moving on as if they're working for Henry Ford in on a production line. So we need to consider, is it a good role for people? So there's all sorts of different things you can consider when you're redesigning who does what. One great thing, we talked about the need to be able to facilitate a workshop, is by engaging each of the different types of staff. So in this particular case, a GP, a nurse, an allied health professional and an admin staff, we can, by introducing and bringing them into it, they're the experts who can tell you what they enjoy, what they don't enjoy, what issues they have with it being split or merged or whatever. So that's great to get them, and you should always get them involved in the conversation. And of course, and we'll cover this in a separate session on its own, getting the service users involved in this sort of discussion is also, I would argue, a great thing to do. So there's lots of different things you can consider. And the way I like to consider them is using a few different approaches. So one is swim lanes, for example, is setting out how the process works by putting them at currently how it works by putting things into swim lanes based on who does it. So, for example, we might consider that administration, the review of the referral is done by somebody, the nurse clinic and handling of admin is done by somebody else, reviewing the referral, reviewing to the tertiary, GP clinic handling admin is handled by somebody else, so that we can place those in swim lanes to see who's doing them at the moment. And that's where we can set out who does what in a process. And it's only when things split between people that we can consider that things often can go wrong. So we can then change our roles by doing that to say who does what. So we could see that the nurse was handling the admin themselves, for example. We can change things so that all of the administration is done by an administrator, that the nursing is done by a nurse, and that the GP clinic stuff is done by a GP, for example. So we can move who does the roles and create roles that way. So that's the first way we can do things. We can change roles around who does what. But we can also aim to simplify it where it's all done by a single person, because that may also be a better role, or it might speed things up. So there's a few things that we can consider. We can consider skill mix changes. So that's moving tasks or roles up or down an existing hierarchy, moving things, so just substituting a different role for another. We can widen the job by bringing together functions which may have been done by different individuals in the past. So, for example, in that particular case, it could be the GP doing everything, for example, or the AHP doing everything. We can job deepen things by giving the role more significant and substantial responsibilities where possible. This often happens when you combine it with digital changes. So moving a medical secretary role, for example, and over time it has been enriched by doing less of the typing and more of the organizing of booking, for example. And then that may change even further with better electronic booking and changing roles where we might have senior administrators managing an entire process where the actual processing itself is done by bots or AI. And we can, of course, create new roles as well. So we can combine new and or existing roles and functions in different ways, creating a new role. Now, new roles are an interesting thing because, of course, they haven't always worked for all sorts of different reasons. So there's been a bit of pressure around certain roles in the NHS, for example, and that is often due to the way in which that role has been communicated, sold in, but also there are other issues with some of those roles. But also new roles, they're all very exciting. But the great thing, especially in the NHS, the health side of health and social care in this country, has been that they're not always supported properly and they don't always fit. The great thing about the NHS has been that we're really good at training certain roles en masse. But if we end up with lots of individual roles, we can end up with a bit of a problem. Even allied health professionals, a staff group in its own right, often don't have a voice at board level. And so, even that big group of staff don't always have the full support through a system. So when we're considering creating new roles, we should always be a bit careful. We need to think about, if we're doing that, we need to think about banding and remuneration. We need to think about how they're going to be supervised, how they're going to be trained, what career routes there are. We need to consider how it's going to be communicated to people, because people might see it as a threat. We need to think about how we're going to budget for them, etc., which can't be easy. We need to think about what unions they'll be involved in, as well as how we're going to engage with the unions around those, for example. So there's lots of things to consider for new roles. But even where we're deepening and widening, we also need to think about these things, especially what makes these roles excellent, what's going to attract people to these roles. Because if people are just doing a repetitive task, are they going to be attracted to it, etc.? And we also need to think about where the process responsibility fits within this process. We need to think about the input to outcomes, who is responsible for making sure that there's good quality outputs for service users. And finally, a great thing we always need is job descriptions to be changed properly so that we've got a really strong job description, because job descriptions really should be a great tool for people to understand what they should be doing, not just something we create to get people through banding discussions. That is it in terms of a quick half an hour run through of workforce redesign or role redesign that we use within the WRaPT process.